Good evening, ladies and gentlemen, excellencies, ministers, ambassadors, colleagues, guests, ladies and gentlemen, both here in Geneva and online from everywhere around the world, joining us for this very important event. Welcome to the high-level event co-organized by the Arab Republic of Egypt, the Republic of Peru, the World Health Organization, and the International Organization for Migration. At a time of complex global challenges, from devastating wars, conflicts, to climate change and natural disasters, non-communicable diseases represent a silent pandemic, placing an ever-growing burden on the global south and disproportionately affecting persons in most vulnerable situations, such as migrants, refugees, and displaced people. We are very grateful for your presence here with us today. And given the richness of today's program and the high-level segment and all of the guests, I would kindly ask all participants and speakers to strictly adhere to the allocated time so we may follow the pace and then come to meaningful contributions and discussions. I will begin by calling out His Excellency Ambassador Ala Higazi, the Permanent Representative of the Arab Republic of Egypt to the United Nations in Geneva. He will be delivering opening remarks on behalf of the Deputy Prime Minister of Egypt and the Minister of Health and Population. Excellency, please.
Excellencies, honorable ministers, distinguished guests, it gives me a great pleasure to welcome you all to this high-level side event on the margins of the 78th World Health Assembly titled Global Health Equity, Shared Responsibility in Addressing the NCDs Burden for All, including migrants and refugees. And it gives me a great pleasure to give this statement on behalf of our Deputy Prime Minister, Dr. Khaled Abdel Ghaffar. I'm proud to stand alongside our esteemed co-organizers, the Republic of Peru, the World Health Organization, and the International Organization for Migration, IOM, in convening this important dialogue on one of the most pressing health challenges of our time. We are equally proud to have 25 co-sponsoring member states and 8 co-sponsoring UN agencies, non-state actors, academic institutions and universities. Their continued commitment and solidarity have made this gathering both very possible and impactful. This event reflects our shared recognition that health equity is a universal right. The rising burden of non-communicable diseases, NCDs, especially among populations of low and middle-income nations and people in vulnerable situations as migrants, refugees, and displaced people, is a defining challenge that cuts across borders, sectors, and society. In Egypt, NCD prevention and health equity are central pillars of our national health agenda. We are committed to inclusive, people-oriented approaches that leave no one behind regardless of nationality, age, gender, or legal status. Our flagship 100 Million Healthy Lives, that's the title, Presidential Public Health Initiative, that's the title of our presidential initiative, stands as a testament to this commitment. We have also expanded access to cancer screenings, tobacco, cessation support, cardiovascular care, and diabetes management with 14 public health initiatives in total, all with an emphasis on primary and preventive care. As the champion country of the Global Compact for Safe, Orderly, and Regular Migration, GCM, Egypt has integrated over 10 million migrants and refugees into national health strategies in alignment with the WHO Global Action Plan for promoting the health of refugees and migrants. However, national efforts alone are not enough. To truly deliver on Sustainable Development Goal 3, we must strengthen global solidarity, secure sustainable investments, and prioritize those who are too often left behind. This side event is not just a platform for dialogue, It's a call to action. It's an opportunity to reaffirm our collective commitment to building more inclusive, resilient, and equitable health system. Let us share experiences, build new partnerships, and act with unity and urgency, ensuring that NCD prevention and care for all remain at the heart of the global health agenda. We look forward toward the high-level meeting on NCDs at the 18th United Nations General Assembly this September. Let us use this moment to build momentum, strengthen political will, and ensure that no one is left behind. Egypt stands ready to work with all of you to advance this vision, and thank you.
Thank you, Ambassador. And now it's my pleasure to call to the floor Dr. Santino Severoni, Director, Health Migration, World Health Organization, to deliver a statement on behalf of the Director General of the WHO.
Good evening, Excellencies, distinguished delegates, colleagues and friends. I'm delivering a speech in behalf of the Director General, Dr. Tedros Ghebreyesus, that these days a little bit busy, so the number of meetings, competing meetings, is quite high. So I'm given this big responsibility to step in and to representing him. Well, I would like to start by acknowledging the special situation of tonight, and this is clearly shown in the previous slides by the number of countries co-sponsoring, international organizations co-sponsoring this event. This is as an indication of the importance of the topic and the complexity of the intersection between health, migration, and in the case of chronic diseases, even more important. Too often when we look at the issue of migration or population on the move more generally, we tend to focus on only what is visible on media. We are not realizing that migration today is accounting to more than 1 billion people, if we are counting international, internal, and displaced population. We do not know that since I started my work as a Director of Health and Migration here in WHO headquarters in Geneva in 2020, the number of international migrants raised from 278 million to 304 this year. The number of displaced people raised from 80 million to 123 million nowadays. Those are data from colleagues and friends from IOM and UNHCR. But this is telling us that we are confronting with an historical challenge, because the number of displaced population is higher also to what we've been observing after the Second World War. And especially in this difficult time where everything is put under discussion, the access to health is one of the issues which often fell into the topic that not necessarily are recognized to be a right for everybody. We've been analyzing very carefully the access, what are the main challenges for this population around the world. And analyzing the access, we realized that countries are very attentively try to define who are those people coming to our countries. So the legal framework tends to be very precise in defining who they are and attributing them a name, but automatically this legal framework is the main barrier in accessing health services, defining my right as a migrant to have an access to primary health care services only, or emergency service only, or a full package like any other citizens. When we are talking about the connection, the intersection between health and migration, often we are stopping observing the negative phenomenon. And I want to use tonight also to remind to everybody the reality. We see also a lot of promising experiences around the world. Countries which they decided, they made the most important step, they politically decide that access to health must be universal, responding to the principle of right to health and for all citizens. So we see countries like Colombia, Uganda, and so on, a certain number of countries which are expanding, granting the access to health sector for millions of refugees and migrants. I mentioned Colombia and Uganda. We are talking about 1.5 million only in Colombia and 1.7 million in Uganda, which the government decided to give them full access. When we look at the chronic disease, we need to spend particular attention because the public health concern in relation to people on the move have been always pointing out to communicable diseases. There is a very easy mechanism of thinking that who's coming from outside, who's coming from the southern part of the world, like often happens with migrants, is a carrier of diseases. That's not true. Any one of us could be a carrier of disease depending where we are exposed to. But there is a very little knowledge of the risk of contracting or to be affected by chronic diseases. And chronic diseases is probably the invisible pandemic we are confronting today from the public health point of view. 70% of the global death are depending from cardiovascular diseases, hypertension, diabetes, mental health, and in many cases, the countries which are supplier of migrants or displaced for the fragile context of the health system, they are also countries where diagnosis of chronic disease is not done or postponed or not detected. So that's why mortality is very important. Tonight, I think, is a precious night, not only because we're going to discuss about this complex interaction, but because we're going to have a lot of countries, Excellency Minister explaining what they are doing in their own context, so it will be extremely rich night to start to translate policy, evidence, data into concrete action. So thank you very much for being here tonight and looking forward to a successful discussion. Thank you, Haitham.
Thank you very much, Dr. Santino. And now it gives me great pleasure to welcome our co-organizer, His Excellency Ambassador Luis Chuquihuara, the Ambassador Permanent Representative of the Republic of Peru to the United Nations in Geneva.
Muchas gracias. Muy buenas tardes. Excellencies, distinguished delegates, ladies and gentlemen, it is a pleasure to co-sponsor this event with the Arab Republic of Egypt, alongside the WHO and the IOM, important partners in international public health, particularly for the most vulnerable populations, such as migrants and refugees. For Peru, both addressing NCDs and the issue of the health of migrants and refugees are critically important. The Latin America region hosts about 17 million refugees, asylum seekers, internally displaced persons, and stateless individuals, highlighting the political and economic significance of addressing their needs. It should be noted that Peru is the second destination country for the Venezuelan population, with nearly 1.66 million people who have had to leave their country. Today, my country is processing more than 500,000 asylum requests received to facilitate the registration and integration of migrants and refugees into our society, including their full access to public and quality health services. In this regard, my delegation welcomes the progress made under the implementation of the WHO Global Action Plan to promote the health of refugees and migrants, which was co-sponsored by Peru. At the same token, Peru has had improvements in the care of non-communicable diseases, such as arterial hypertension and diabetes, which has increased of 6% between 2021 and 2023 in the amount of people who receive treatment. This has gone hand in hand with measures to reduce risk factors such as excess weight, which data has shown had also decreased on average in the same period. Attention to non-communicable diseases in the primary care level has been strengthened with the Health Initiative, which aims to improve the prevention and control of cardiovascular diseases with a comprehensive approach to their main risk factors, including arterial hypertension, diabetes mellitus, and chronic kidney diseases. The Health Initiative is an ambitious program that strengthens the capacities of health personnel and contributes to a better design process for the necessary indicators to evaluate the implementations of this strategy. From its own experience, Peru is convinced that continued on-site interventions by WHO are essential in order to provide specific recommendations to better address the medical needs of refugees and migrants, who will redouble efforts to partner with UNHCR and other specialized institutions to pool greater resources to fund work in this area, particularly related to NCDs. In the current context, where the number of forcible displaced persons continues to increase due to wars, economic crisis, and the effects of climate change, Peru has maintained a consistent position on the protection of migrants and refugees, promoting their social inclusion on equal terms with others, which undoubtedly includes safeguarding their health as it pertains to NCDs. In a global context marked by humanitarian crisis and complex situation of human mobility, Peru continues to strengthen its institutional capacity to ensure improvements in the diagnosis and treatment of NCDs across all segments of our society, including persons on the move. Before concluding, I want to thank our co-sponsors and partners organizations and wish you all the successful and fruitful Health Assembly. Muchas gracias.
Thank you very much, Excellency. And now, last but definitely not least, Dr. Poonam Dhavan, Director of Migration Health Division of the International Organization for Migration, on behalf of the Director General, Ms. Amy Pope.
Thank you, Haitham, and greetings indeed from the International Organization for Migration, from our Director General, the leadership team here at headquarters, but also warm greetings from the many IOM offices around the world that work with our member states, several of whom are here in the room today. Excellencies, distinguished colleagues, it is a pleasure and an honor for IOM to join you here today. I join my colleagues at WHO in thanking the Arab Republic of Egypt and the Republic of Peru for co-hosting this event with us, and the many member states, UN agency partners, and other stakeholders for co-sponsoring and participating in the event. The growing burden of non-communicable diseases is indeed a defining global health challenge around the world. It also tests the inclusiveness and resilience of our health systems. For IOM, working closely with our member states and partners, delivering on the promise of migration while serving the most vulnerable is central to our strategic plan. And our strategic approach on migration health calls for migrant-responsive health systems and equitable access to healthcare within and across borders. For too long, migrants, refugees, displaced communities, and those living also in hard-to-reach locations have remained at the margins of national and global NCD plans. Yet, these are the very communities and individuals that face fragmented access to services and can be disproportionately affected by the social determinants of health, from housing and nutrition to education and employment, especially in crisis and displacement settings. At IOM, operating in more than 170 countries, along borders, in camps, in transit hubs, as well as within destination and return communities, we see firsthand how individuals living with diabetes, cardiovascular disease, cancer, or mental health conditions can struggle to access and maintain care as they move or when health systems are disrupted. But solutions exist. Migration-aware health systems, mobile technologies, portable health records, and regional care frameworks can transform how we reach and serve migrants. But these solutions require political will, sustained financing, and most importantly, partnerships such as the ones we hope to build here today to support continuity of care. As we prepare for the high-level meeting on NCDs during the upcoming General Assembly, we welcome the emphasis placed on equity and inclusion in the 2025 Secretary General's Progress Report. It affirms what we see in our operations, that migrants and refugees with NCDs and mental health conditions need structural changes to happen in order to ensure that the challenges do not continue to grow, whether caused by climate shocks, political instability, or forced displacement. Allow me to conclude by noting that IOM stands ready to work with our member states, the UN system, civil society, academia, private sector partners, and others, including migrants themselves, to deliver on the cause we are here to discuss today, because health for all must indeed include everyone. We look forward to the discussions here. Thank you.
Thank you very much to our four co-organizers, Egypt, Peru, IOM, and WHO. And now it gives me pleasure to welcome the honorable ministers and the high-level segment of this event. First of all, His Excellency Dr. Etienne Abela, Minister of Health and Active Aging of Malta. Excellency, if you can join us. His Excellency Dr. Haitham Mohamed Ibrahim, Minister of Health of Sudan. I can't see very well from here, but His Excellency Dr. Magid Abu Ramadan, Minister of Health of Palestine, but I don't. Okay. His Excellency Dr. Javier Padilla, State Secretary for Health of Spain, who is coming straight from the airport to the side event, so thank you very much. His Excellency Ambassador Antonio da Costa Mira Gomez, Permanent Representative of Portugal to the United Nations in Geneva. His Excellency Archbishop Ettore Ballesterio, Permanent Observer of the Holy See to the United Nations. Distinguished panelists, we will start off by very short remarks that each one of your distinguished selves would make, reflecting on national reforms that are made and commitments that are made to combat NCDs with inclusion of all populations and ensuring health equity. We will start with His Excellency Dr. Etienne Abela, Minister of Health of Malta.
Good evening, and thank you very much for the very kind invitation. And again, I commend the Republic of Egypt and Peru for taking this initiative. I'm going to talk about the local situation in Malta. Obviously, Malta is at a crossroads. It's, geographically, it's exactly in between Europe, Africa, and the Middle East as well. In Malta, we have a system that includes universal coverage for health, and that includes migrants, it includes the asylum seekers that present to our shores. That means that we offer the full service to these persons as if they were citizens. Now, that includes primary care options, and with primary care there are screening options, albeit many a time these are younger persons who, at the time being at least, do not qualify, for example, for colon cancer screening, just to mention one example. Where our current age for inclusion is 50 years and more. But then obviously the coverage includes secondary and tertiary care, which we offer in our hospitals. So that is the situation at a glance. There are situations, one might mention, where a person might present with certain specific diseases that we don't actually have the expertise to deal with in Malta. And in such situations, we are supported by colleagues abroad in the UK, mostly. So that is the situation at a glance. Thank you.
Thank you very much, Excellency, and thank you very much for also sticking to the time. Thank you. Now, I would like to ask His Excellency Dr. Haitham Mohamed Ibrahim, Minister of Health of Sudan, to make his reflections as well.
Thank you very much, Haitham. And first, let me also to thank the sponsors and the co-sponsors of this very important event, Egypt, Peru, IOM, and WHO. And let me also to send a special thank to Egypt now for hosting more than 2 to 3 millions of refugees or IDP from Sudan due to the war in the country currently. And of course, most of those now in Egypt and in other countries having some sort of NCDs, renal diseases, cancers, etc. For that reasons, addressing such issues is very important for a country like Sudan. And many countries like Sudan, of course. Now, just we heard from the presentation from WHO and from IOM, the movement of the population is heavy around the world, either due to causes like wars or disasters or free movement. But at the same time, we need to address the issue. We need to ensure equity of services for those visiting other countries. The second point I would like to address before moving to Sudan and its context, the distinct issue about the NCDs, and it is from an epidemiological point of view, and it is natural history, long natural history, not like other diseases. It is starting even before birth and up to the end of the life. That means it is a continuous disease. For that reason, it is a chronic disease. For that reason, we need to address throughout the life of the people, and starting from the health promotion up to rehabilitation. For that reason, it is not easy to address NCDs or to manage NCDs unless we work across the continuum. And the third issue I would like to address that Sudan is like other countries facing this double burden. Yes, historically we used to face communicable diseases like malaria and others. But currently, we are facing this double burden. Now, NCD is contributing more than 55% of deaths and mortality in Sudan. For that reason, we need to address, like other countries, this issue. And at the primary and community level, we have some sort of interventions through community health workers, through frontliners, and integrating the addressing of NCDs at early stage at primary healthcare level. We hope these interventions at least lead to less numbers of those seeking for tertiary and secondary care. Of course, it is very expensive, heart diseases, renal dialysis, cancer. Now Sudan is adopting a policy that patients with chronic diseases like end-stage renal cancer for dialysis, for example, end-stage renal failure for dialysis, and also patients with cancer, they are receiving free care inside the country. Even during the war now, they are receiving free care inside the country. And this is very expensive for the country. And this is a huge load, actually, for the country, unless addressing these issues in early stages. Now, for example, we have a number of patients with cancer with renal dialysis in Egypt. And also we address this issue with our partners, with WHO and also with other partners now to find a way of how to support Egypt, for example, through some of the programs, through WHO, through IOM, or through KSA, Saudi Arabia, for example, how to support other countries to fund managing the patients coming from Sudan. And for that, I would like to end with a suggestion. Poonam said that we need like a regional framework that need commitment of the countries and the government. And I would like to say like a regional or cross-border finance, cross-border health insurance program, especially for chronic diseases. If not the whole spectrum of the disease from early or primary healthcare, at least insurance program, cross-border insurance program for those in need and the service is hard for them to pay, like renal dialysis, like transplant, like cancer, for example. And the international organization like IOM or others or WHO think how to find a budget or a basket budget for those migrants or for those refugees, how to finance this insurance program. Of course, this will benefit not only Sudan, and will benefit this large number of IDPs, refugees, and migrants all over the world. Thank you very much.
Thank you very much. Thank you very much, Dr. Haitham. And now moving to a Spanish perspective, Dr. Javier Padilla, please.
Thank you very much. It's an honor to be here with you, and thank you for the organization and to the sponsors. First of all, I have to say that I think that in Spain, the situation of the healthcare coverage for migrants and refugees is not the result of a concrete decision, but the result of our National Health Service structure. So I should outline that the coverage we have for migrants, it's not only for documented migrants, but also for undocumented migrants. That is something that for me is on the core of our coverage health system. Another thing that I think that is very interesting is that, in our opinion, the best way to include migrants and refugees is treating them and covering them in the same way as original population. So we have no distinction in the degree of services that migrant population and refugee population and migrant, documented and undocumented migrant population have this right. The thing that we are facing now is how to close the gap between the entitlement and the access, because we know that we have a universal health coverage right and in the framework of right to health, but we also know that in many situations, most of them related to the social determinants of health, but many others related to cultural aspects, we know that migrant and refugee population don't have the same access, even though they have the same degree of right. And we are working in some some things. First of all, we are now in our parliament discussing and developing a law in order to regularize, to document 500,000 of undocumented migrants and now in Spain. I think this is the way of throwing away the main barrier that they have, and that is the regular situation. The second one is recognizing the right to health beyond the legal or status, but also beyond the job situation. So we have linked the job situation and the right to health. And the third one is we are trying to work at a clinical level, at a health assets level, on accessibility at a bureaucratic, at a cultural, and at a clinical level in order to close the gap between the migrant and refugee population and the non-migrant and non-refugee population in Spain.
Thank you very much. Thank you very much, Dr. Javier, for your insights. And now I move to His Excellency Ambassador João Antonio da Costa Mira Gomes, the Permanent Representative of Portugal to the United Nations.
Well, thank you very much. Let's move to the other side of the border, from Spain to Portugal. And first of all, thank you so much for the invitation. It's a pleasure for me to join this important discussion. In Portugal, we have recognized for a very long time that equitable access to health is both a national priority, but also a global responsibility. Health is a universal right enshrined in our Constitution and implemented through our National Health Service, a system which is based upon solidarity and inclusion. Refugees, asylum seekers, and migrants in Portugal have full access to essential health care, including for NCDs, regardless of their legal status, like in Spain. However, as we know, access alone is not enough. Migrant and refugee communities face linguistic, cultural, legal, and socioeconomic barriers that limit their ability to benefit from full care, especially for NCDs, where the risk factors actually are amplified by the trauma, the stress, and the disrupted care. To address this, we have been working on a national plan for the promotion of interculturality in health, a tool for operationalizing health equity through concrete, inclusive measures focused on vulnerable populations, particularly migrants and refugees. And let me just very briefly focus on three key features. First, this plan is rooted in social participation. We would like also that migrants and refugees are also co-creators of solutions, not just passive recipients of those solutions and that care. Secondly, it promotes social intersectoral collaboration. Tackling NCDs requires action beyond the health sector, like housing, education, employment, and also involving social, civil society and local communities. And third and lastly, it's action-oriented. We are implementing strategies such as trained health mediators and interpreters, community-based awareness campaigns, also integrating mental health care and psychosocial support. You know, we believe that these efforts also strengthen social cohesion, trust in institutions, and resilience. And this is a journey that we are committed to learning, sharing, and collaborating to advance inclusive NCD care and to build bridges with our partners like the ones that are sitting here today with us. Thank you very much.
Thank you very much, Ambassador. And now, His Excellency Archbishop Ettore Balestrero, please, we would like to hear from the Holy See.
Yeah, thank you. Good evening, everybody. Our, let's say, perspective based on human rights, I would say, first of all, to commend the linkage made tonight between health equity, human mobility, conflict, and climate vulnerability. Because this convergence for us is also, let's say, a moral responsibility. Healthcare must be recognized as a universal human right, a right which extends also to those in precarious or undocumented situations. As we know, as the Catholic Church knows too well, through the, I would say, its extensive network, which provides health care and other support for migrants and refugees, discontinuity of care or ruptures in treatment endanger lives and undermine human dignity, undermine solidarity and justice as well. Migrants and refugees so are not and should not be considered a burden, but rather a challenge to grow and embrace in solidarity. At the foundation of all this, of course, is the respect for their dignity, the dignity of human persons. And as the Pope, our new Pope Leo XIV has said, citizens and immigrants alike should be respected in their dignity. And access to quality and affordable health care should not be conditioned on immigration status. So this is why, as just to make a long story short, as we move towards the high-level meeting on NCDs and the WHA78, as Holy See, I'm happy to reaffirm our commitment towards a future where the right to health becomes a reality and a reality for all, both regardless of their status. Thank you very much.
Thank you very much. Thank you very much. We've heard from neighboring Portugal and Spain. We've heard from the Holy See, from the brotherly country of Sudan, despite of everything that it's going through now. And we've heard from Malta, situated right there in the center of connecting Europe, Africa, and the Middle East. So please join me in giving a very warm round of applause to the distinguished panelists. Thank you very much once again to our esteemed ministers and ambassadors. And now it gives me great pleasure to call on board the representative of the government of Indonesia on behalf of His Excellency Mr. Budi Gunadi Sadiquddin, the Minister of Health. Again, I do not see very clearly from here, but seems they're not here. And now, on behalf of His Excellency, Mr. Pradeep Podel, the Minister of Health and Population of Nepal, we'd like to call on stage the Deputy Permanent Representative of Nepal in the United Nations in Geneva. Okay, one person that I see for sure now is the Deputy Permanent Representative of Japan, Mr. Yoshizani Ichi. I see him for sure, yes. Please. Please, yes. Yes, please. Oh, okay. Yeah. They're alone. No, you'll be joined. And on behalf of His Excellency Dr. Saleh Al-Hasnawi, the Minister of Health of Iraq. No. Dr. Samuel Posikai Tapo, Director of Corporate Services and Policy Planning Unit of the Ministry of Health of Vanuatu. Yes, please. Dr. Abdel Karim Mizian Belfiqi, Secretary General of the Ministry of Health and Social Protection of Morocco. Dr. Jose Armando Villamarin from the Ministry of Health of Cuba, Public Health of Cuba. Please. So yes, people start appearing. I just don't see everyone from here. And I would also like to call to this panel now Mr. Daniel Mick from the Health and Migration Department of the WHO. Thank you very much, esteemed colleagues, for joining us here today. As the keynote address is mentioned, this morning we have more than 25 co-sponsoring member states, which shows that there is a global commitment in achieving this equity and access to healthcare and combating NCDs and being very inclusive to all. I will start with Cuba. And I would like for you to please shed some light on how Cuba is tackling this.
Thank you very much for inviting us to this important activity. Thank you to the Egyptian Ministry of Health and Population and the rest of the co-sponsors. Well, the situation in Cuba in 1959 was very hard because the life expectancy in Cuba was lower than 60 years. The infant mortality rate was over 60 per thousand live birth, and around 6,000 medical doctors in the country. The government decided to graduate many health professionals, and at the end of the last year, for example, around 80,000 medical doctors in Cuba. It's one of the highest relations between the medical doctors and inhabitants worldwide, and one of the other things that was very important for us in the health system, it was in 1984, the creation of the family program, family doctors program. That means that one medical doctor and one nurse that are working in a doctor's office covering the 100% of the population of the country, and they are living within the community, because they are part of the problem that are affecting the community. And we use at the primary healthcare level, we use some tools for example, the health situation analysis, where we analyze all the problems that are affecting the individuals, the families, and the community. And we use some other tools that we call dispensalization, but it's like an assessment that we do for all the population. We visited all the houses of the people, and we made a control of all the chronic diseases, for example, and then we include them in the group 1, apparently healthy, the group 2, with any kind of risk. The group 3 is the people that are sick with chronic diseases or others, and the 4th group is some people with any kind of sequels. And then regarding to that classification that we do for the population, then we make a plan for the consultation to visit their homes or they visited the doctor's office. And then that allows us to, for example, that the life expectancy that was lower than 60 years, at the end of the last year, it was over 78 years in the Cuban population. And we try, despite all the problems, all the challenges that we are facing every day, we don't have a lot of resources. We make a control of the diabetes, the high blood pressure, and we are including some initiatives for the World Health Organization, the Pan American Health Organization, like heart. And then I think is the way that we are try to make a control of the chronic diseases. I'm not talking about migrants or refugees because that is not a real problem in Cuba, the migrants. We receive temporal migrants from different Caribbean islands or other countries, and the refugees is a small amount of people that we have. We have a resolution that was signed by our Minister of Public Health just for the attention to the refugees that we have in Cuba.
Thank you very much for this perspective and insights, even though Cuba does not have a lot of migrants or refugees, but the solid work that the healthcare system is putting together for the people. Now I would give the floor to the Deputy Permanent Representative of Japan, Mr. Yoshizani Ichi.
Good evening, and thank you for, it's a privilege to be here with other excellencies, and it's even more daunting to talk in front of ministers and also excellencies here. But I'd like to first start off with thanking the government of Egypt and perhaps Peru for organizing this. We know today is an auspicious day, a very good day, because we just come out with managing to pull off the pandemic agreement and the treaty. I think it's a really good day in a long time for us. Of course, there's a lot of work to do, but this is one. But today, I've also been to a meeting where we're talking about tuberculosis in the morning, and you just recognize that how much more there is to do. And it's really the real killer is not actually the pandemic, but NCDs and tuberculosis, and then there's a ginormous task to do. So Japan has always thought about universal health coverage as being one of the most global goods that we need to pursue from a long time ago, from 1990. So we've come a long way. In terms of Japan, we're a bit like Cuba. We don't have a lot of migrants, but we do think of the need of the host community, which is taking in the refugees. And the refugee issue has been close at heart because of someone called Madame Ogata, who has headed the UNHCR for a long time ago. And we always believe that there's so much burden on the host community, and therefore we need to find a way to get the host community to look after the migrants, but also at the same time make sure that they don't feel left out. So this is where we think in the realm of also health that this can be applicable, and we do try to do that. We're not succeeding everywhere, but we try to do that. The other thing I might say is that for Japan has been a long-living nation for many years, and the average life expectancy is about 83 for ladies and 81 for men, and around that area. But the world has caught up very fast, and now I believe that their life expectancy is 70 globally, over 70, which is amazing, but for me. So we've come a long way, but also means that NCDs is going to be a burden for developing countries and developed countries alike. So I think it's one of these things that we can see as a common challenge for humankind after these 30 years. It's really become a global challenge for everyone. We can learn more from everybody, and Japan is in the same boat. So I'm really here to ask and hear from what others have in their mind. Thank you.
Thank you very much. Yes, I would just like to re-emphasize the last point that you made, that everyone could learn from everyone's experiences. There's something that each country was able to achieve, and if we can collectively put together those achievements, then we can do something that matters for the global population. Now I would like to ask another island state, our dear Dr. Samuel Tapo from Vanuatu to share his insights. Thank you.
Thank you, moderator. And firstly, I just wanted to acknowledge the honorable ministers that are in the room and all the other dignitaries. Thank you very much for giving this opportunity to Vanuatu. All of us know where Vanuatu is, right? Okay, yes, there are a few show events. So
I haven't been though, so I know where it is, but I want to visit.
And now you met me, so now So Vanuatu is located in the South Pacific. We have roughly 310,000 people, 83 islands. Our health system is mainly run by tourism. We are considered one of the happiest countries in the world, so yes, definitely you can come and visit. We are also prone to natural disasters. We have cyclones every October to April every year. We just had the recent earthquake 7.4 just recently. So the immigration or the migration point of view that I'm bringing here is about climate change and how sea level rise has had an impact on our small islands and how people are moving. And I think it's something that we have integrated in our NCD strategy and policy, and it's also been captured under the National Security Council within our country as a priority for the government to also consider it under the immigration policy. So it's something that we have already, as part of our well-being going forward, we have already incorporated it into all our national policies. The struggle that we are having is that in the event when there's a natural disaster, when all the vegetation in the gardens are affected, water is affected, we normally rely more on imported goods. And I think that is where our struggle is in terms of food security versus prevention of NCD. And that is where we are trying to at least regulate the content of salt, content of sugar that comes in the products into our islands in the event where our vegetation tries to come back in terms of growing back to provide for our people. So that is one of the challenges in that area. The other one in terms of when we have the amount of patients that are in the wards now are increasing in terms of NCD patients, and it has put more burden on our health financing. So we have relied more on the additional support that we receive from donor, and considering, I think, our good honorable minister from Sudan mentioned about dialysis, cancer, and these are treatment, chronic diseases that are putting more strain on our system. So I think for that, we are trying our best to rely more on support that we receive from overseas and our nearby countries to assist us to provide that additional support to our system. I'm just cautious of time, so I'll keep it there. There's so many things that I want to talk about today. I'll just keep it there. Thank you, moderator.
Well, thank you very much, and we will have time to further discuss things at the reception afterwards. And I'm very grateful to all three of you for being very punctual with the time. And now I bring back the perspective to my mother continent, to Africa, and to our neighbors in Morocco to share their personal perspectives.
Thank you very much. I'll read the statement on behalf of the Minister, His Excellency the Minister of Health of the Kingdom of Morocco. So, Excellencies, distinguished ministers, ladies and gentlemen, allow me first to express Morocco's deep appreciation to the Arab Republic of Egypt for hosting this timely event and for placing the health of migrants and refugees at the heart of our regional and even global dialogue. Egypt, like Morocco, is at the same time a country of origin, transit, and destination. We recognize the immense efforts made by the Egyptian authorities to respond to complex migratory dynamics while ensuring across access to basic services and safeguarding human dignity. These are challenges we share and values we jointly uphold. Guided by the high vision of His Majesty King Mohamed VI, may God assist him, Morocco launched in 2014 its national strategy for immigration and asylum grounded in human rights and inclusive integration. In this framework, Morocco ensures non-discriminatory access for migrants and refugees to primary health care, hospital emergencies, and public health programs, including vaccination, maternal and child health, reproductive health, and chronic disease management. We also provide free essential medicines and regular outreach in high-density migrants areas, but also in all the kingdom, in close collaboration with civil society. Migrants and refugees are further integrated into Morocco's broader social protection reforms now, giving them access, as all the Moroccan citizens, to health insurance, family benefits, pensions, and unemployment support. We fully endorse the spirit of the Rabat Declaration, promoting resilient health systems, reducing vulnerability, and ensuring fair access to quality care for all, including migrants and refugees. Excellencies, Morocco remains committed to a human-centered, rights-based approach to migration, where health is seen not as privilege, but as a shared responsibility and a fundamental right. Thank you. And this is for the statement, the official statement. I have some time. So this is my, my statement. It's not a political one. It's my personal view. So for all, we are facing difficult times. For all those who are forced to quit their jobs in these times, please feel free to join Morocco as migrants. We will welcome you.
Well, I think we should end at that. But thank you for keeping to the time, reading your minister's statement, His Excellency the Minister of Health, and also making your personal remarks, all within the time. And now, after we've heard from different member states, we bring back the dialogue to the WHO and its tremendous efforts that I think everyone has mentioned repeatedly, how much we appreciate, and we think that WHO's role is vital to this. So I give the floor now to my good friend Daniel to put his insights.
Thank you very much, Haitham, and many thanks to Egypt, Peru, IOM, all the co-sponsoring member states and organizations for convening this excellent event. Yes, we heard during this event, we heard excellent examples from the countries, which I will try to summarize in one sentence. What it needs is the political commitment, investment, then some partnerships or collaboration with UN agencies, and understanding that refugees and migrants can be not only beneficiaries of the national health system, but can also contribute as healthcare workers, as interpreters, as cultural mediators. So where WHO comes in? So we have this mandate by member states as a WHO Global Action Plan on promoting the health of refugees and migrants, which was in 2023 extended until 2030. And earlier today, WHO member states approved the program budget 26-27, which have a specific output on refugee and migrant health. So WHO is really equipped together with the global strategy called GPW14. Obviously, we know what's going on. Everybody saw the organigram. So this is the reality we are facing. But how we are supporting member states? There are several areas: advocacy and partnership. This event is an example of this. Technical assistance. So we are supporting countries in strengthening their responsiveness of their health system to the needs of refugees and migrants, but also to the host populations. Capacity building, health workforce, but also health and non-health sectors through Global School, our flagship initiatives. Data, this is something that we have developed, we have put in place a sort of baseline to measure the progress under the GPW14, so to understand how member states progressed in implementing the refugee and migrant health. But also we have launched last year a dashboard of promising practices, and what I heard today here from the member states, it would be excellent, to add your examples also to the dashboard. We also do normative and research and knowledge generation products. We launched this series on a global evidence report on refugee and migrant health. We launched 3 reports that are related to this event, one on NCDs, one on mental health, and the last one on dementia, which was launched in March 2023. And all these reports provide evidence on the barriers and on the sort of challenges that refugee and migrants face, but also they provide the recommendations, evidence-based recommendations for policymakers to include these populations into the policymaking. And since my time is coming to the end, let me use this as a call for action. We heard several times the reference to the UNGA high-level meeting on NCDs. So let me call, on behalf of WHO and other UN agencies in the room, on member states to make sure that refugees and migrants are included in the political declaration. So there is a commitment adopted by member states to include the refugee and migrant health in the context of addressing the NCDs globally. Thank you very much.
Thank you very much, Daniel. Thank you to Morocco, Cuba, Vanuatu, and Japan for your insights. Please join me in giving the panelists a big round of applause. Now, please, I would like to call His Excellency, Dr. Seleso Matos, the Minister of Health of Sao Tome and Principe, to the stage, please. And also please welcome Dr. Alan Maina, the Chief of Public Health Section of the United Nations High Commissioner for Refugees. And to bring an academic view to the discussions, I would like to call upon Dr. Gabrielle Fabreau, Associate Professor of the University of Calgary, Canada. And also please join me in welcoming Ms. Keith Long, Senior Migration Health Advisor at IOM. Mr. Cesar Garrido, President of the World Federation of Hemophilia. And last but not least, Ms. Caroline Holt, Director for Disasters, Climate and Crises at the International Federation of the Red Cross and Red Crescent Societies. So we'll begin by giving the floor to His Excellency, the Minister of Health of Sao Tome and Principe. His Excellency would prefer to give his brief remarks in Portuguese, and our colleague will translate right away.
Muito boa noite a todos. Meu amigo Artem, muito obrigado pelo convite.
Bon, je vais faire la traduction en français, vous permettez. Donc, Son Excellence veut vous remercier à tous, surtout notre ami Artin.
Quero dizer que nós somos de São Tomé e Príncipe.
Nous sommes de l'île de São Tomé et Príncipe, c'est un archipel aussi.
2 ilhas situadas no centro do mundo.
2 îles situées au centre du monde.
E também não estamos isentos das doenças não transmissíveis.
Nos problèmes aussi, c'est les maladies non transmissibles.
Excuse me, Excellency, I just want to make sure, can everyone understand French or should we translate into English?
Faz inglês, pode falar inglês.
English or, okay. All right, you can do French and then I will do English.
The best for us is Português.
Ok. Quero dizer que nós não temos muitos imigrantes internos. Temos alguns imigrantes da nossa sub-região, alguns, que beneficiam de todos os serviços de saúde igual que qualquer national de notre pays.
Dans nos pays, on n'a pas beaucoup d'immigrants ni réfugiés. Mais les petits qu'on a bénéficient de toute façon de tous les droits au niveau de santé qu'on a comme l'autre citoyen normal.
So in Sao Tome and Principe, there aren't many refugees and migrants, but the little that are there, they benefit from all healthcare services just as citizens do.
Em todo caso, ultimamente, nós temos outro problema, que são os nossos cidadãos que estão a emigrar para a Europa.
Malheureusement, les dernières années, on a l'autre problème. Ce sont nos citoyens qui sont en train d'émigrer pour l'autre pays.
Okay, so we've faced recently another issue is that we have migrants going to third countries.
E, infelizmente, esses nossos cidadãos que migram, não têm, são imigrantes que vão à procura de melhores condições de vida em outros países e quando chegam lá não encontram aquilo que esperavam. E têm estado a passar grandes dificuldades e trazer um problema social não para o país para onde imigraram, senão também impactam também no nosso país porque estão longe, mas solicitam apoio ao nosso país.
Donc, malheureusement, le grand problème d'immigration qu'on a, sont en train de sortir pour l'autre pays, ils n'ont pas le même accueil dans le pays qu'ils sont en train de recevoir. Et malheureusement, quand ils sont en train d'arriver là-bas, ils sont en train de demander l'appui au gouvernement de São Tomé e Príncipe.
Portanto, é problema.
Okay, so unfortunately, the migrants or the refugees that go to third countries, they do not receive the healthcare services that they ought to receive as other citizens, and in that case, they would ask to return to Sao Tome and Principe.
Esta foi uma introdução sobre a situação em São Tomé e Príncipe.
C'est une introduction au niveau de situation à São Tomé e Príncipe.
Que, mesmo sendo país muito pequeno, 1001 km²,
même soit comme un pays très petit de 1001 km²,
nós sofremos o impacto das doenças não transmissíveis.
Nous sommes en train de souffrir l'impact des maladies non transmissibles.
Okay. Bearing in mind that my French is not even that great, but despite the fact that Sao Tome e Príncipe is a very small country, 1 million square.
No,
1,000. Yes. 1 million would be Egypt. 1,000 square kilometers. But you are in the works of adopting the new framework for non-transmittable diseases.
Agora queria abordar um pouco aquilo que eu vejo na televisão.
Alors, je voudrais très rapide faire une approche qu'il est en train de regarder sur les télévision.
E vejo notícias de refugiados em campos de concentração.
Il regarde les news, les informations dans les champs de concentration.
Em vários países.
Ou ailleurs.
E eu...
I think you have to make a translation.
No, please continue. I'll make it all
Continue.
together.
E eu me pergunto, agora eu estou encarando agora a realidade de que eles também sofrem das doenças não transmissíveis.
Maintenant, avec cet événement, il est sûr qu'avec la disposition que beaucoup de panélistes sont en train de prononcer ici, que la plupart des réfugiés sont en train de souffrir les maladies non transmissibles.
E eu tinha a sensação de que fossem mais doenças transmissíveis.
Il avait la sensation qu'il a eu les maladies transmissibles qui non transmissibles.
E eu é uma responsabilidade de não só dos países que recebem os refugiados.
C'est une responsabilité des pays, pas seulement les pays qui sont en train de recevoir les réfugiés,
Mas toda a comunidade internacional.
toute la communauté internationale.
E eu acho que os modelos de maior sucesso no controle das doenças não transmissíveis.
Donc le modèle de succès de contrôle des maladies non transmissibles
Deveriam ser replicados nesses ambientes.
Doivent être multipliés dans cette ambiance.
Porque são pessoas com várias situações, separação da família.
Parce que ce sont les personnes fragiles avec la séparation des familles et tout ça.
Frustração.
La frustration.
Objetivos e problemas familiares, alimentação, imagino que sofrem uma série de dificuldades pelos quais mereciam, se calhar, mais collaboration.
Ils souffrent beaucoup avec les problèmes de séparation familiale, alimentation et tout d'abord, de toutes les autres situations, notamment la frustration et les problèmes mentaux qui doivent avoir un meilleur accueil de la communauté internationale.
Portanto, Santo Tomé e Príncipe é um país com muitas dificuldades, não temos muito a oferecer, mas quero juntar a nossa voz para a causa dos refugiados.
Comme vous savez, Santo Tomé et Príncipe, c'est un petit pays avec la fragilité, mais nous sommes ici pour ajouter nos voix à tout le monde pour aider au niveau de fragilité de ces groupes fragiles. Merci beaucoup, je vous remercie.
Thank you very much, Minister. So the Minister was saying that you see a lot of suffering on television of the migrants and refugees and what they go through, but he heard very positive things today from the different panelists and how those migrants and refugees, they suffer equally as citizens do from non-communicable diseases, and that to overcome this burden, it has to be a collective global action. It cannot be done separately and independently in each country. And even though Sao Tome e Principe is a small country, but His Excellency's presence here today shows that they are committed to be part of this global agenda to make sure that migrants and refugees have the access to healthcare services, and they no longer have to undergo the suffering and separation that families go through. I tried my best. Thank you. Okay, so now I would like to ask IOM, Ms. Keith Long, about the efforts that IOM has been doing. We know that you play a very active role within the UN family in providing and supporting member states, making sure that migrants and receive healthcare access on equal footing. Please.
Yes, thank you so much. And good evening, everyone. I know we're standing between you and your dinner, so we'll keep moving. But I think you heard in the keynote from Dr. Poonam, Dhavan, in terms of the role of IOM, and it's very much an operational role, and we stay very focused on that in terms of supporting member states and communities to realize progress towards migrant and mobility sensitive health systems. So I do want to touch, and we've heard many examples already tonight, on kind of three key areas that we see as opportunities to addressing systematic barriers to accessing NCD and mental health care for migrants and their communities. And the first grouping is around what we've been committing to, and member states and WHO and many partners, in terms of bringing health services closer to the realities of people. And I think for migrant populations and displaced populations, this has the greatest hope in terms of delivering. And from the IOM perspective, you heard over 170 countries where we're present. You know, I wanted to highlight a few. And the first one is in Colombia, for example, where we've been supporting community-based NCD care for migrants and indigenous populations, combining access for primary health care with culturally informed approaches like community health networks and local health action planning. Another example is in South Sudan, where we've been helping to integrate NCD into mental health screening into emergency services with adaptations driven by community feedback, and that's an important part, involving migrants, involving their communities in designing the care. And that ended up in adaptations including, for example, extending clinic hours. And my third example is some of the work we're doing with the governments of Mozambique and South Africa on the border in terms of building in NCD screening, like for hypertension, for diabetes, into occupational health checks for migrant workers, alongside testing, of course, for TB, HIV, and other lung diseases. The second point, I have 3 points, so this is the second of three, is to connect also to an intervention from the distinguished delegate from Sudan and the reference to regional frameworks, regional health insurance schemes. And I want to make the point underlying this is also strengthening of data systems, both in terms of the data that patients hold in their hands, and I want to make that point, making sure that people are empowered to carry their records with them is really critical, and we see that in a lot of our operations. And I think AI, technology provide a lot of opportunities for us to do this faster. But also in terms of supporting many governments to strengthen the harmonization of data systems across borders. And I think there's a lot we can learn from many regions in terms of the efforts that have been done for communicable diseases, and in terms of blocks of member states being able to advance their systems to speak to each other. And my third and last point, and I think it was Spain that mentioned this also in their intervention, is around the UHC, the Universal Healthcare Coverage reforms. And many countries, as they go into reviewing their national health systems, have the opportunity to really make those instruments more inclusive. And I think we have also noted in many contexts there is a dependency or a reliance to providing access for non-citizens primarily to emergency services, and that we know does not serve the efforts in terms of advancing non-communicable and mental health care. Also an emphasis on notifiable diseases, but I think a lot that could be done there, and from the IOM perspective, to take it further in terms of sensitizing healthcare workers, building their capacity so they understand the rights of access for migrants. I just want to leave on one point, and I joined WHO in the previous panel in highlighting the current moment that we're in as we move towards September, and the high-level meeting on non-communicable diseases and mental health conditions. And we note currently in the language of the draft, it does refer to vulnerable and marginalized communities, including those in emergency settings. But it does not yet name migrants, many of which who are not displaced or not refugees. So we look forward to the deliberations in the next couple of months and weeks. Thank you so much.
Thank you very much. Yes, we know that the zero draft came out 3 days ago, I believe, yeah, and there is a lot of room for deliberation, and we look forward to that. I would like to now ask Dr. Gabriel from the University, Associate Professor from the University of Calgary, who's coming all the way from Canada, so that shows commitment, and to share his insights, please.
Thank you, Haitham. And my many thanks to Egypt, gracias a Peru, and to IOM, WHO, and everyone for attending and for the invitation. My experiences as an internal medicine physician and specialist, I also co-direct a refugee health research program in Canada and work across in North America. And it's in those experiences that I've come to understand that there are three major challenges with NCD care, specifically to migrants and refugees, that I wanted to address. The first is competing priorities and silent symptoms. And so it is often told to us that patients or refugees and migrants may not understand the importance of these conditions. But when you're a migrant or a refugee and you're facing discrimination, exclusion, difficulty, just surviving, you have to prioritize food, water, shelter, employment, education for your kids. It's not that you don't care about your hypertension. It's also that the symptoms of these NCDs are often silent. And so your uncontrolled hypertension, your uncontrolled diabetes can go on for a long time until it doesn't. And they can lead to devastating organ failures, complications, and suffering, and healthcare costs that are many times more of what they would have been had we been able to intervene early. That's the first issue that we see constantly. The second is they're chronic diseases by nature, which makes them long. Global health systems and healthcare systems developed out of episodic care for infectious diseases. We treat the malaria, it's gone. We did it, it's over. But hypertension, diabetes, some of these long-term chronic cancers, they are chronic, which means they're with patients for lifetimes. And health systems, especially for migrants that are migrating and mobile, health systems in my experience, have not been adapted to be able to manage. I've not yet once read about a health system that I've studied from around the world. I've heard some amazing things tonight, but I haven't heard of a system that can afford to care for every NCD patient as the prevalence continues to rise globally, everywhere, every day, for every lifetime, for as long as people live, and to be able to do that efficiently. And so the only way as physicians, as practitioners, what we try to do, the gold standard is to empower our patients, empower communities to be able to manage their care on their own, and by extension, help their communities. And so the third, and this is the most important problem that we see, is trust. You can build the most advanced health system with the best medications and the greatest tools, but if your migrant and refugee communities do not trust those systems, they will not engage. I've trained in places with the most sparkling equipment and the empty hallways where people will not come because of fear, because of trust, and these are things that are happening obviously today in North America. And so there is one solution that we found. It's very elegant, and we call it, it's inclusion, it's in participation. It's some of the things we've heard from KIT and from some of the other member states. It was really heartening. What we learned is if you include, if you take community-based participatory methods, if you include communities to help co-design programs for themselves, they're calibrated for their communities. One, they're far more effective. You will get the reach to the communities that you want. You will get the treatment that you want. You will get the efficacy that you want. The second is you will get innovations that are far more efficient. And by efficient, I also mean cost efficient, far reducing the cost burden. And then third, there are some side effects. Once you have community members that can then broker trust, they'll bring in other community members. Those other community members will spread the word and can actually spread promotion and prevention activities. And then the last, which is a researcher, which I love, a side effect that we learned is once you have that trust, you can then have then help you generate the ground level data that is almost absent globally. And they can help you do it in ways that you wouldn't have thought of. So for me, my big fear about NCDs as someone who manages them and studies them is that we're losing or we're quickly forgetting all of those lessons that we learned painfully in COVID. Many systems around the world had to adapt. They rapidly made inclusive health systems where they included their communities to increase their reach to vaccination, to prevention, contact tracing, et cetera. And it feels to me like some of those lessons were lost. So for me, I just want to echo what Kit said and some of the other community members. Some of the things we heard from the member state in Cuba is that if you can get into the communities, if you can garner trust, that is the magic ingredient that can help. Thank you.
Thank you very much, Dr. Gabriel. Again, we can't emphasize enough, awareness, innovative solutions, good leadership, and strong partnerships across borders. I would then bring it back to the United Nations and ask my dear brother, Dr. Alan Maina, the Chief of Public Health Section at UNHCR, to bring his insights to this discussion, please.
Thank you very much, Haitham. And yes, no, it's a very illuminating discussion, and I could repeat a lot of the messages that have been said by the previous speakers. We're all speaking around the main message around inclusion. And as you know, UNHCR is working, or some of you may know that we're working in over 130 countries. We talked about the number of people displaced, reaching 123 million, which within that number, over 30 million are refugees. We're seeing these numbers continue to grow, but we're in a situation where there's continuous poly-crisis, where you have conflicts, you have the effects of climate change, as well as the financial situation that is going on around the world. The socioeconomic conditions are difficult. The rhetoric is challenging. Even when you talk about inclusion, the reality out of here we see in the news is that exclusion is still an issue that is happening and is creeping in many of the contexts that we work in. I think the main things around, let's say 3 points. One is around the inclusion being an opportunity, and I liked the Honorable Delegate from Japan reminding us about the High Commissioner, Sadako Ogata, who emphasized the importance of working and including both refugees, migrants, and the host community in every program that we do. Equity pays. His Excellency from Sao Tome also mentioned this thing about this emphasis on working for both refugees and host communities. And we've seen studies that have shown the opportunity we get out of inclusion. It's not only the dividends you get out of the public health outcomes for refugees, but also the aspect that we don't have to talk about, the economic dividends for the host community. And we see health, good health outcomes means that they need to be able to access education, they need to be able to have the right to move, they need to be able to have the right to education. If you only sort of one aspect and you don't look at the other aspects, then you have a paradigm shift that doesn't result in suitable health outcomes. And the NCD being the silent epidemic that we are seeing in a lot of our consultations, 6% of the consultations we are seeing in facilities where we have the data and we're able to monitor, so on NCDs, and hypertension and diabetes are among the top. And it's among the top 4 causes of mortality in these operations. It's a worrying trend that we're seeing the number of NCDs going up. And it's a situation where you still talk about inclusion being an opportunity, but you still find that there are still gaps where in countries with 70% of the refugees being in low and middle income countries, the fragility remains an issue. In some of the remote areas where we're talking about need for inclusion, health systems are weak and they're not able to get the simple diagnostics for NCDs, the treatment that they need. How can you talk about inclusion as an opportunity if we don't strengthen those systems? And this brings me to an example where we've not talked about the private sector. And we're working, for example, with the World Diabetes Foundation and Danish private sector entities in Kenya to strengthen the systems and being able to ensure that the remote areas are able to have the right human resource and capacity and diagnostics to be able to treat NCDs. We're also looking at innovative approaches to provide more cost-efficient services. The community engagement aspect in terms of the inclusion being and resilience has been talked about. And in Bangladesh, we have seen great examples of the community being able to follow up on treatment and being able to ensure that even during COVID time, this proved very helpful to make sure that we can guarantee continuity of services. The reality right now is that if we don't address inclusion now, we don't address the crisis that comes tomorrow. And you can't overemphasize that point. But you also need data. And the data, Gabriel talked about some of the evidence and work that is going on. But the reality is we don't have enough information on the situation of the NCDs among refugees and migrants around the world that can be able to inform the high-level meeting that we're having in terms of the dividends and also the gaps that we're seeing in the inclusion of these communities in the national programs. The policy and practice remains a challenge. We have good policies. We have situations where most of these people are saying the refugees and migrants are not able to access these services because of various barriers, including financial barriers. And so if we don't address the social determinants, the economic determinants of health, we're not going to be able to reach that target that we have on inclusion and what we would like to celebrate in terms of universal health coverage and being able to get ahead of this silent epidemic that is going on. Thank you.
Thank you very much, Dr. Allen. And now I would like to ask Mr. Cesar Garrido, the president of the World Federation of Hemophilia, to please add his remarks.
Thank you very much. Good evening, everybody. Excellencies, distinguished guests. The World Federation of Hemophilia thanks the organizer for this kind invitation to co-sponsor today's important side event. The World Federation of Hemophilia applauds the WHO 14th General Program of Work agreed in 2024 to prioritize refugees and migrants' health as a key global health agenda item, including the focus on promoting collaboration towards implementing health policies, systems, and action plans tailored for refugees and migrant populations. The report last year quite rightly stressed the importance of highlighting the success and challenges that member states face in this regard. We fully endorse the focus of today's discussion in terms of fostering dialogue and strengthening collaboration towards equitable burden sharing to ensure that no one is left behind. Not the person requiring our support and not the member states that are doing the utmost to support them. The World Federation of Hemophilia expresses our solidarity with all members of the bleeding disorders community who are either refugees or migrants under the strenuous situation in various regions of the world. Often, they face key challenges in terms of access to care and treatment, whether while being displaced internally in the countries they leave behind or in their host countries. The key challenge is to ensure that people with hemophilia have access to prophylactic treatment, which is often a key challenge for these vulnerable groups. The WFH facilitates access to treatment to people with hemophilia, including when it's feasible for refugees and migrants, through donated shipments of life-saving treatment products through our humanitarian aid program. The WFA urges the WHO and all parties to ensure and facilitate access to treatment for affected communities. We stress the importance of ensuring that hospital and medical facilities remain operational in their countries of origin affected by conflict, so that all people who need medical assistance can receive it. The WFH is deeply grateful to host countries such as the Arab Republic of Egypt and also Ireland, Poland, and Lithuania and Germany, who have gone over and beyond their means to support affected members of our bleeding disorders community. We call on all member states to adopt policies that are geared towards more equal burden sharing to ensure that the health system in host countries are supported and that the affected community have equitable access to care regardless of where they live. Thank you, and we look forward to continue engagement with you all on progressing this agenda. Thank you.
Thank you very much. Thank you very much, Mr. Cesar. And last but not least, we'd like to hear from the International Federation of Red Cross and Red Crescent Societies. Ms. Carolyn Holt, please.
Thank you. Thank you very much. I'm delighted to be here this evening with you, and thank you for staying. I'm also delighted to represent some gender diversity with Kit on this panel as well, on all of these panels tonight. But seriously, I'm here. I work for the International Federation of Red Cross and Red Crescent. We are present in 191 countries globally. You know us, you know our national societies. We are the Swiss Red Cross, we are the Bangladesh Red Crescent, we are the Sudanese Red Crescent. You know us, and there's 191, so really representing that community voice. But also just to say that last year, 85% of what we responded to as a network was climate-induced. Climate impacts and climate crises. And I want to look at this topic through that lens. Because we're talking about people who are forced to flee multiple times because of floods and storms and droughts, people who remain displaced for long periods of time, unable to return home, people who move from rural to urban locations, often to maybe unsafe informal settlements, and people who don't have access necessarily to the healthcare that they need. Scientific evidence also tells us that with a worsening climate, we will see more of this. We've also heard that NCDs are on the rise more generally across the population, which means that they are also on the rise amongst those people who are on the move. The prevalence of this really means that we need to make sure there's that continuity of care across borders and to make sure that there is trust, and trust was the word that was mentioned earlier. I think that is critical, and that's something that we as a network really put a lot of emphasis on, because without trust, we're unable to reach people, we're unable to include people, and we're unable to satisfy and support the needs of the most vulnerable amongst us. We know also that the care needs to range from regular preventative to more urgent access, and making sure that we have the systems in place and the ability to address across that whole range is something that's increasingly important with a population who rely solely often upon organizations such as ours in terms of being able to access and working very closely with ministries of health in countries to also be able to systematically be included in the healthcare access of those contexts. Within the Red Cross and Red Crescent network, our own mapping exercise has found that already in 49 contexts, we're implementing NCD interventions in emergencies, which includes with migrants and with people on the move. We also know that the IFRC has developed an NCD Vision and Framework 2030, which has been developed together with more than 70 countries. It emphasizes the need for preparedness to see this worsening climate, to see this worsening crisis in terms of people who will be relying upon us. And that growing momentum was echoed just last week during the global NCD Advocacy Bootcamp here in Geneva, which I understand had the participation of more than 60 people from member states, Red Cross, Red Crescent, national societies, and it was really looking at the protection of NCD supply chains, financing MHPSS care. So, what can we do? We need to prioritize and invest in climate-resilient health systems to make sure that we're foreseeing the future health crises and making sure that we're including all members and all profiles across the population in that. We need to make sure that our approaches are embedded in community-based health structures. Communities are on the front line, and our frontline responders often. We need to make sure that we are supporting them, not only protecting the health of those healthcare workers, but also engaging and building those health structures based upon the needs of the people that they serve. No top-down-ism, but really engaging and embracing and having those people for whom the services are provided really input into what they want to see. We need to make sure that we're able to access those that are the most difficult to access, and inclusivity is absolutely critical. We need to make sure that we are not only tailoring these and adapting our approaches, but we're providing equity across the board as well in terms of who can access. We need to make sure that when we send messages that we're following up. Not everybody who receives a message knows what to do with it, knows what it means for them, and knows then what their action should be. And we need to make sure that our health systems are also reaching out and engaging people in ways that are meaningful for them. Sustainable funding and resources, we know that at times, certainly like this, certainly across the humanitarian sector, the resources are becoming more and more squeezed. But we need to make sure that not only are we continuing to secure those sustainable resources, but that they are reaching the right level. If they don't get down to community level to include the people who they're aimed for, they are not necessarily doing the full work that they can. So, in summary, empowering local structures, fostering community participation from those that we are trying to serve, really, and ensuring that the funding and the resources go to the levels that they need to, is really one of the key ways that we'll see some meaningful supports to people living with NCDs. Thank you.
Thank you very much. Well, again, everyone stressed inclusivity, cross-sectoral collaboration, civil society actors, the government, private sector, making sure that there is sustainable financing. And we've heard from government, we've heard from the UN, we've heard from non-state actors, we've heard from academia. And I think we can all agree that the rise in NCD prevalence is continuing and can only be stopped through this very collective, very holistic, collaborative approach that we see today with all of the member states and all of the non-state actors that have joined this event. Thank you very, very much to the esteemed panelists. Kindly join me in giving them a very loud round of applause. Ladies and gentlemen, excellencies, distinguished guests, since we have run out of time and we do not have any room for questions and answers, I would just like to give the floor to one last very short statement from the delegate of the Bahamas, Dr. Philippe Swan, who would make a small intervention.
Thank you, Etienne. As was mentioned earlier, our regards, of course, to the governments of Egypt and Peru, IOM and WHO. Equity is a word that conveys different meanings depending on the context, whether it be among peoples, communities, cities, provinces, countries, and regions. The same is true when discussing which priorities are greatest when speaking about NCDs. And finally, migrants and refugees come from many different contexts, and the response that they require demand different approaches and considerations. The fact of global equity being a shared responsibility then has a context that is unique to each member state, and that requires specific attention and evaluation to determine what equity means in a particular circumstance. As many developing countries struggle with addressing equitable health services within their own borders, the idea of global health equity is something that, for some, may be further away in terms of priorities. For the Bahamas, which is a country of 700 islands, 2,000 rocks and keys over an area of 100,000 square miles between Florida and Haiti and Cuba, we understand that equity with respect to NCDs within countries speak to ensuring that screening services, early diagnosis, treatment, and the prevention and management of morbidity must be available in each of what we call our main population centers. As you can imagine, this in itself is a challenge from even a manpower perspective. There is a need to reframe the approach in a way that is fiscally responsible while ensuring that the equity balance is not abandoned. When we turn our attention to migrants and refugees, we have another perspective to consider. Thankfully, the Bahamas is not a recipient of war-torn refugees, but we do have our fair share of migrants, documented and otherwise. The challenges here are really based on the concern of how do we balance the diagnosis and treatment of chronic conditions in individuals who may be repatriated from a continuity of care and do no harm perspective. And how do we ensure that we are maintaining the treatment regimens that individuals, be they migrants or refugees, are under in their home countries. This topic was just partially addressed during the global high-level technical meeting on non-communicable diseases in humanitarian settings, which was held between the 27th and 29th of February 2024 in Copenhagen, Denmark. This was further briefly touched on in a preparatory meeting in the Economic and Health Dialogue of the Americas held in Punta Cana in Dominican Republic in March 2024. During these meetings, the main point of contention is how do we even ensure that the medications that are used across borders are the same medications? How do we find a nomenclature that is standard across borders, and even within groups of countries that speak the same languages, there are different terms used to refer to the same medication. So even as we begin to revisit the whole idea of global health equity, there are a number of steps that must be taken to ensure that the foundation on which we build has the tools that transcend borders and cultures. As I conclude, I must commend the progress that WHO has made in developing nomenclatures and standards for medical equipment and devices. I believe this is one of the foundation pillars that will aid in the determination of how equity can be accomplished. This, along with the WHO NCD best buys and standards, as well as management and treatment standards across WHO regions like HARTS in the Americas, is another tool that can be used. So once again, I thank you for the opportunity to be a part of the dialogue, and we look forward to the recommendations and ideas shared here as we seek to shape our experience and respond in a way that is best aligned with realities we face and the ideals we pursue as a global community. Thank you.
Thank you. So, to wrap up this very important event on the margins of the 78th World Health Assembly, I believe that despite everything that the world is going through now, despite of all the devastations that the world sees, I think that this is a very positive note that we can take out this evening, that from small island states, from developed nations, from low-income countries, middle-income countries, we have all gathered here today, and non-state actors, the United Nations, and we all have the same message, we all have the same goals, and I believe that with very strong leadership, with inclusion, and with real belief that equity can be reached, that this is not a mere dream, but something that can be accomplished. Thank you all for joining us today, and thank you all for your commitment, and we look forward to working closely and collaboratively in making sure that the UN high-level declaration is inclusive and member states work in upholding it. Thank you very much.